welcome everyone to the first ever video conference being hosted by the Collective Power of One International. I'm the host, Dr. Dale Climie, and I'm here to introduce the moderator for this evening's discussion, and she is Dr. Satya Kalengi, and she is an internist and a gastroenterologist, and also the executive director of the Collective Power of One International. So, Dr. Satya, I shall turn it over to you.
Well, thank you so much, Dr. Climie, for that introduction. And it is our pleasure indeed to have such dynamite speakers for our talk this evening. And welcome every guest from across the world. Thank you so very much. I will just share that this will be recorded as well, and therefore will be shared across the globe. We have invited several people across the globe as well. However, given the time differences, the chances are that they are unlikely to join. Nevertheless, the message will be disseminated throughout. So I want to thank both of you for joining us. At this time, it is my pleasure to introduce to you Dr. Tracilyn Hall. She is an assistant professor of Gynecologic Oncology at Baylor College of Medicine. She works tirelessly to ameliorate healthcare disparities for cancer patients in low resource settings. She's passionate about ensuring her patients from all backgrounds have access and support they need to navigate their complex health systems in order to receive their cancer care. She is board certified in gynecology, oncology, as well as obstetrics. She's completed her fellowship at Mass General, Harvard School of Medicine, did her residency at the Houston Methodist and at Cornell after graduating from Texas Tech University with her medical doctorate, And our next speaker is Dr. Claire Hoppenot. She is an assistant professor in gynecology, oncology at Baylor College of Medicine, and she's completed her residency and fellowship at the University of Chicago at Northwestern. She did her medical college education at the Jefferson Medical College in Philadelphia. And she is equally a passionate young lady for providing cancer care across the continuum from prevention to pre-invasive disease to surgery and chemotherapy to the end of life care. That is very touching. She cares strongly about working with underserved patient populations. She aims to partner with patients and their families to find options most suited to their diagnosis and goals. She's also interested in research, and her research has been focused on patient experience with malignant bowel obstructions. And she's working on developing a communication aid to facilitate decision-making at the time of these kind of difficult diagnoses. So today we are privileged by having both of them, and we are going to have an interactive session between Dr. Hall and Dr. Hoppenot, and I am looking forward to it. So it is now yours, all yours.
Well, thank you so much.
Yes, thank you for having us. We're absolutely delighted to be here and be sharing some of what both Dr. Hoppenot and I are very passionate about.
What we wanted to do with our talk was focus on gynecologic cancers in general, and sort of highlight what we think is most important for people to know about each type of gynecologic cancer that we encounter and that we see, unfortunately, every day in terms of what to look out for and sort of the patterns that we see in these cancers, and focusing on really the things that we think are the most important for each of the cancers. So as we mentioned, I'm Claire Hoppenot, and I'm here with my colleague Tracilyn Hall. We really appreciate the invitation to speak today. We're very excited to be sharing sort of what what we do every day. So this is generally our outline in terms of the main questions that we want to answer for these cancers.
So one of the questions that I get, Dr. Hoppenot, from a lot of patients is, what exactly is the gynecologic tract and what organs do gynecologic oncologists treat cancer involving?
That's a great question, and it is a question that we get a lot in terms of what is our job exactly. So as gynecologic oncologists, we do care for women with cancer, and the cancers that we focus on are the ovaries, the womb or the uterus, the vagina, the vulva, as well as the cervix. The fallopian tubes can also sometimes be involved in cancer as well. The cervical cancer itself is the fourth most common cancer throughout the world in terms of incidence and death in women worldwide. And it is the cancer of, as you can see circled here, the lowermost part of the uterus. It's the part that you can see in the vagina, which will be important in terms of screening. And unfortunately, 84% of the cervical cancers and 88% of deaths will occur in lower resource countries. We're showing a map here of the world, and you can, in the darker areas here, the redder area, and so that's part of why we want to focus on it in this talk as well. It can be sort of highly more prevalent in places that don't have access to good screening.
So even though cervical cancer is the most common worldwide, uterine cancer is going to be the most common of what we see here in the United States. So uterine cancer affects the womb, and there's actually different forms of uterine cancer. Within the uterus, there is the endometrial lining, which is what a woman sheds every month during her menstrual cycle. That can form a cancer known as a carcinoma that comes from the glands of the uterus. But the womb itself actually has really thick muscular walls called the myometrium, and that can actually form a cancer as well, which is called a sarcoma, and that tends to be a highly aggressive form of cancer that we see in our practice. So again, kind of pointing out the difference of where the womb is and the different parts. So on the right of the screen, we've highlighted the endometrial canal, versus the left of the screen is that thick walled lining where we have those sarcomas develop. And you can see all of this is in close proximity to the cervix, which is what Dr. Hoppenot just talked about as the most prevalent worldwide of the gynecologic cancers. But then it's also close to the ovary and the fallopian tube, making our accurate diagnosis very important in both imaging as well as surgical modalities.
The last main type of cancer that we see is going to be ovarian cancer. The ovaries are on the side of the uterus. They are connected to the uterus by the fallopian tube. And interestingly, cancer that starts in the fallopian tube as well as the peritoneum, which is represented by this blue line, which is really the inner lining that is throughout the entirety of the abdomen. These cancers, starting with whether it's from the ovary, the fallopian tube, or the peritoneum, actually acts very similar. And so we treat them all as the same, even though they start in slightly different places. The most common type is going to be serous ovarian cancer, and that is the one that we'll focus on throughout most of this talk, although there are other types of ovarian cancers. There are also many ovarian tumors that are not malignant, that are benign, as well as cysts on the ovary, which occur every month in a premenopausal woman who's going through the menstrual cycle. And those are not cancer. They don't turn into cancer. They're completely normal, but they can be something that can be seen on imaging or felt during an exam as well.
So one of the questions that I get asked is, can we prevent gynecologic cancers? And it really varies on the type of cancer that we treat. So with endometrial cancer, there is no definitive way to prevent it. There's actually no good screening for endometrial cancer, but we can look for risk factors that patients have. So we do know that there are associations between obesity and uterine cancer or endometrial cancer. As a patient gets more and more obese, they actually store peripheral estrogens in that additional fat tissue that they carry, and that can stimulate the uterus to have an overgrowth of that endometrial lining, putting them at the risk for carcinoma. The other thing that we can look at as a risk factor is looking at hormone replacement therapy. So in women that take estrogen replacement without progesterone, again, has that effect of stimulating the uterine lining and increasing their risk of cancer. Ovarian cancer is another type of cancer that we can't prevent, but we do know, again, there are certain risk factors for it. Specifically, there are some genetic syndromes like the BRCA, associated familial patterns, where patients can actually undergo a bilateral salpingo oophorectomy and lower their risk of ovarian cancer. This does involve removing both the tubes and the ovaries, because like Dr. Hoppenot said, we do actually have cancer that starts in the tube that we describe or call ovarian cancer because it behaves the same way and looks the same under the microscope.
So cervical cancer, on the other hand, is something that we can prevent because it's something that can be caught before it actually turns into cancer. More than 90% of cervical cancers are associated with a virus called human papillomavirus, or HPV, which is sexually transmitted and is incredibly common. I tell women that most women will have HPV if they're sexually active at some point in their life, and most women will clear it on their own. However, for some people, for an unknown reason, the HPV tends to stay, and that over time, which can be usually years to decades, can cause some precancerous changes on the cervix that over time can turn into cancer. And this is actually something that we can prevent. There is a vaccine against HPV. The vaccine covers some, but not all of the strains of HPV. The one that we're most commonly using actually covers 9 strains of HPV, including HPV 16 and 18, which in the United States account for 80% of cervical cancers. Other parts of the world may have slightly different proportions of which type of HPV is prevalent. However, 16 and 18 are still at least 60 to 75% of cancers around most of the world. And the HPV vaccine can actually prevent a woman, or actually a man, from getting HPV and being able to pass it on, and it can actually prevent cancer. We actually do recommend vaccination now for all 11 to 12-year-olds in the United States, which can be either a 2-shot or a 3-shot regimen, depending on the age at which you're giving it. And it's recommended for both boys and girls at that age, which is important in part because boys can transmit HPV if they're not vaccinated, and so putting girls who will be women at risk. But also because HPV can actually be associated with other types of cancer, including head and neck cancers, and that can affect men and women equally. And here I talk a little bit more about other types of cancers that are associated with HPV. And so you can see cervical is one of the main ones. The vulvar and vaginal ones are also ones that we see frequently, but anal and oral or head and neck cancers are less frequent, but can also occur. And then penile cancer is also less frequent, but can occur because of HPV.
So I definitely have patients and specifically parents coming to me with concerns over the HPV vaccine. So one of the big questions that I get asked is, we say HPV is a sexually transmitted disease. So if we give our daughters a vaccine, will it lead to promiscuity? What do you think, Dr. Hoppenot?
Well, they've actually studied it because it wasn't just enough for us to say, it won't, this is worth it. And there have been retrospective studies looking within the United States at teens in 23 states with pro-HPV vaccines versus those without. And they didn't see in self-reported surveys any difference in promiscuity. They did retrospective studies of high schoolers as well. So they had a campaign of mandatory vaccination of 8th grade girls. And they looked 2 years before and then 2 years after of this mandatory vaccination to see if there was a difference in sexual activity in these girls, and there was no difference. And likewise, looking at unplanned pregnancy, STD rates in vaccinated and unvaccinated girls, it did not show any difference. So I think that this can be reassuring beyond the fact that this vaccine can prevent cancer, which I think is worthwhile regardless, but that this does not seem to increase sort of promiscuity in girls who have had the vaccine.
Another question I get is, it's a virus. So if you give me a vaccine, will it actually give me the human papillomal virus?
So the way that the vaccine has been created actually does not have any viral parts. So it's trying to stimulate your immune system against the virus. And the way that it does that is it actually took a little portion of the capsule that covers the virus and put that in a vaccine form so that your immune system can see the capsule and attack the capsule without having any chance of the vaccine giving HPV.
Another question that's definitely hot on everyone's mind is it safe? Do we have long-term data showing that it's not going to cause harm?
And we do. We've had this vaccine now for 10 years. And so we have no, nothing in the data that's showing any suggestion that this would not be safe or that there are adverse effects that would be concerning from the HPV vaccine.
What about, has it worked? We've got this great idea of preventing the infection with HPV and preventing cancer, but does it actually work? Is it worthwhile?
And again, people have followed up on this. In a long-term follow-up of this vaccinated population, they didn't see any pre-invasive lesions associated with the HPV targeted by the vaccine. So unfortunately, the HPV vaccine does not cover all HPV strains, but they can tell which strain is causing the precancerous lesions, and they could tell that there are no precancerous lesions from the HPV types in the vaccine. Likewise, cervical cancer rates have decreased by about 1/3 among girls 15 to 24 years of age. And that's a big deal. I mean, these are not the people that we see as often, but these are the people that are the women that are going to have gotten the vaccine. And the fact that we're actually seeing a decrease in the rates of cervical cancer suggests that this HPV vaccine works. And this is even outside of a place where we don't have mandatory vaccination for everyone. So it's not, the uptake is not close to 100%, it's closer to 50%. And so even with that, cervical cancer rate seems to have decreased.
It's pretty incredible. It's kind of surprising that we don't have mandatory vaccination. Is it mandatory anywhere?
So there have been, there are places that do have universal vaccination. And I just wanted to point out Agnes Binagwaho, who was a speaker at our Society for Gynecologic Oncology conference a couple years ago, who's a pediatrician from Rwanda, who was the Minister of Health from 2011 to 2016. And she instituted universal vaccination in Rwanda and was actually able to go across the country, with this refrigerated vaccine and get it to more than 90 to 95% of the population of young girls in Rwanda. And so this is a place where, you don't usually think of Rwanda as someplace having a lot of resources, but they were able to actually get to all of their young girls and institute universal vaccination. So it is something that's possible. They found that it was absolutely safe. There did need a lot of education to the families because many people were not excited about having a vaccine for HPV or for a sexually transmitted disease. But with good education, support from the authorities, which were government authorities, church authorities, and who helped provide the education and support, they were able to go out and do this vaccination, which is incredibly important. I think that one other thing that I hear a lot about is, I have patients with new cancers who will say, I just don't, it's not in my family. Nobody in my family has cancer. Why do I? How did this happen? Or who are worried about whether this is something that can affect their children.
Definitely a great question because, we think about cancer and it's actually surprising that not all cancers run in families. With uterine cancer, again, that's the most common cancer of the gynecologic tract here in the United States. Only about 3 to 5% of all women with endometrial cancers actually have a genetic syndrome that predisposed them to get that endometrial cancer. So specifically Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, is a cancer syndrome associated with increased risk of endometrial cancer. In this cluster, patients will have a family history of colorectal cancers as well as uterine cancers, but they can also have other cancers in the family caused by this syndrome, including cancer in the stomach, the liver, the kidneys, the brain, or even the skin. And all of these cancers tend to occur at a pretty young age. And that's how we kind of, as oncologists, can be prompted to recognize this may be related to a syndrome. When you see a lot of cancer in patients less than 50 in a family, it definitely triggers our intuition to look further. And this is something that we now will routinely test at the time of diagnosis, because we can easily diagnose a Lynch syndrome patient based off of a biopsy or off of a hysterectomy specimen. Other cancers that can run in families include ovarian cancer. So here it's still not every ovarian cancer that we treat, but it is about 15% of the ovarian cancers that we see that are genetically related. The most common that we're going to see here is going to be BRCA1 or BRCA2, and these patients are going to have a family history of breast cancer in both men and women in the family, as well as ovarian cancer, melanoma, pancreatic cancer, or prostate cancer. And then Lynch syndrome, just like it can increase somebody's risk for getting endometrial cancer, can actually increase their risk for getting ovarian cancer as well. What about cervical cancer, Dr. Hoppenot?
So cervical cancer does not seem to run in families because it is related to HPV. There have been reports of families where the mom, daughter, aunt, where there are high numbers of cervical cancer, and it's unclear whether some of that is sort of the environment or socioeconomic versus if there is a predisposition to not be clearing the virus that we just haven't been able to test for or know about. And I do think that that's an interesting area of more research. But as far as we can tell, there are no cancer syndromes associated with cervical cancer. So, Dr. Hall.
Yeah, so definitely one of the things that I get asked is, how do we screen for these cancers? So when we look at doing screening, we're going to be looking at an asymptomatic patient population. So somebody that actually isn't yet knowing that they have any signs or symptoms related to any of these cancer diagnoses. And the goal of screening is going to actually be to detect precancers or precursors that will then develop into cancers. Or the other idea with screening is you can actually catch a cancer very early on while it's still a stage 1. And that's because most cancers take time to develop. Precursors can invade, eventually becoming cancer, but you can catch them at that pre-invasive disease before they've actually spread when you're doing screening. And this is something that, the idea is hopefully to catch it before it ever becomes a cancer. So Dr. How do we do that?
I think the best example is really cervical cancer and the pap smear. So the way that we do it for cervical cancer is that because the cervix is just at the very top of the vagina, we're able to place a speculum, see the cervix, and then take a scraping of the surface. It's not done with every pelvic exam, but it can be done very easily. And at the same time, we can send that scraping and tissue to for HPV testing as well, so that we can see if there is HPV there that would also put you at risk of having a cervical cancer precursor or cervical cancer itself. We recommend it about every 3 to 5 years, even after the HPV vaccination, starting at age 21, along with a routine pelvic exam. And the most important part seems to be really the HPV testing, because the chance of having cervical precancers or cancer itself is so low without HPV. When we started routine pap smears in the United States in the 1980s, cervical cancer decreased by 50% because we were able to catch the precancerous lesions and take them out before they even turned into cancer. And so that's part of why what we're seeing here is that most of the cervical cancers that we see are in women that aren't part of routine care, or who, for some reason, which can be multiple reasons, aren't able to see a doctor very regularly or even once a year in order to do these pap smears. It's important to remember the pap smear tests only for cervical cancer and cervical precancerous changes. I find I have so many women that come in saying, with endometrial or ovarian cancer, saying, but I get my pap smears every year. How is this possible? And unfortunately, the pap smear does not test for those cancers. And so it's not something that we would have caught earlier. Dr. Hall, is there anything we can do to test for those cancers?
So one of the things that we can do is just doing a routine exam. So when we do a pelvic exam, we really look at the vulva and the perineum. We want to make sure that there's no lesions, nothing that looks abnormal. And we want to take a good history from the patient and make sure they haven't seen anything new or felt anything new on their body. We also want to look inside the vagina with a speculum exam as well as at the cervix. With this, we do have to, even though it's not the most comfortable, use that speculum to really get a 360-degree view of the vagina, because you can have cancers that arise anywhere within the vagina or within even the cervical-vaginal junction. So we take our time and we really do our due diligence for each of these women by looking with the speculum. And we're going to feel the vagina as well as the cervix. We're going to feel the shape as well as the size. And we're going to look for mobility of the uterus. Whenever there is a cancer present, one of the things that will happen is it will get fixed to the tissues around it as it invades other structures. And so some mobility in the uterus is actually a good normal sign that we want to see in healthy women. And then we're going to feel the adnexal region to see if we can feel any large ovarian masses. Even in reproductive age women that are very slender, the ovaries shouldn't be very large. So really any ovary that's bigger than about the size of a grape or even a small clementine is going to be abnormal and prompt us to do further workup. So when we look for cancer precursors with endometrial cancer, there is actually a state called hyperplasia where you have overgrowth of that endometrial lining that's not yet cancer. When we talk about that overgrowth, there can actually be a change within the cellular architecture in the nucleus called atypia. So typically what happens is you'll have simple hyperplasia without that atypia or without that change in the nuclear architecture. But then eventually patients can develop complex hyperplasia where there's lots of glandular crowding as well as atypia, and that's going to be really our precursor to cancer. With this, a lot of patients will actually let us know by coming into the office that there's some abnormal bleeding pattern or any bleeding after menopause. Bleeding after menopause is never normal and is something that every woman should go and seek care because it could be a precancerous state or even a cancerous state that needs evaluation. And it's something we can easily evaluate with doing our pelvic exam. Not all postmenopausal bleeding is cancer, but again, it really all needs to be evaluated because of that risk. And this is something that we can evaluate with doing a pelvic ultrasound and a biopsy in addition to our pelvic exam to actually help make the diagnosis. With ovarian cancer, there's also a precancerous lesion. Specifically, Dr. Hoppenot had mentioned earlier in the presentation that serous carcinomas are the most common type of ovarian cancer. Well, they can actually be linked with what's called a stick lesion, which stands for a serous tubal intraepithelial carcinoma. That's something that just hasn't invaded, but given time, would actually invade and become an invasive cancer. We can also see what are called borderline tumors. So a borderline tumor isn't benign, meaning that it's not a functional normal cyst that would develop just with ovulation every month, but it's also not cancer. It's something slightly in between where you have some abnormal growth and you can even have some of that architectural change within the cell. And so some borderline tumors, if left in the body, can go on to develop into cancer. So it's important that when we see these, we actually take them out to prevent any cancer from developing. But it is also very important to note that there really is no good screening tool for ovarian cancer, which is part of why, unfortunately, the most common stage at diagnosis is 3C. And so that's something that, again, is a great opportunity for research in the future. And we've got a lot of smart people working on it, and hopefully we'll come up with a better way to screen for ovarian cancer at some point.
So what can we do?
What symptoms do you usually see when patients do present, Dr. Hoppenot?
So I think that the symptoms that we see, and that I will tell women, particularly if they're high risk for developing these cancers, to be watching out for, definitely abnormal uterine bleeding or abnormal vaginal bleeding or discharge can be seen across the board. Even vulvar cancer, to be honest, it's not vaginal bleeding, but it can cause some blood to be noticed in your underwear from a vulvar lesion. For cervical cancer, because most of the time it is caught before it has spread outside of the cervix, that is the main symptom. If it is becoming a sort of a larger cancer, I would be concerned about pain. but for the most part, abnormal uterine vaginal bleeding. And this can mean, for cervical cancer, usually it can be bleeding because of trauma from intercourse. And so bleeding after sex can be a concerning symptom, and you would want to be evaluated for that. Ovarian cancer, this is the one that I talk about most because ovarian cancer is very difficult to screen for, as Dr. Hall was saying, or to catch early. And so something that we rely on is just what a woman is feeling. And so some of the things that we can see with ovarian cancer includes abnormal vaginal bleeding or discharge as well, feeling full too quickly or difficult eating, so feeling very bloated, feeling like the appetite or the amount that you're able to eat is a lot lower, pelvic pain or pressure, frequent or urgent need to urinate or constipation, bloating, and abdominal or back pain can be the most common. And these are symptoms that really are part of daily life for everyone, which is part of what makes it hard. Everyone has some of these someday or other. So I usually tell women, if it's been there for 2 weeks, then I would want to hear about it and we should look into it. But if it's there for a day, gone for a day, comes back a couple of days, that sounds like living daily life. Uterine cancer, as Dr. Hall is mentioning, thankfully tends to present with abnormal vaginal bleeding. And so it is something that can be caught early because of that. If it is a little bit more advanced, it can be associated with pelvic pain or pressure. Vaginal cancer, which we have not talked very much about, but likewise can have some abnormal vaginal bleeding, as well as if it's big enough to press on the bladder or the rectum, then it can be causing some symptoms from the bladder and the rectum, like a need to urinate or constipation. And then vulvar cancer comes from the vulva, which is the outer lips around the vagina. And that tends to be associated with itching or burning or pain or tenderness of the vulva in that area, or seeing a change in the skin or feeling a change in the skin or a new lump or bump in that area.
So I have to say, vulvar cancer is actually something we haven't talked much about, and it's something that does make me very sad because a lot of women actually don't think to do an exam on themselves. So like Dr. Hoppenot was saying, the vulva is the skin outside of the vagina. It's the lips around the vaginal entrance, and it's an area that we don't actually talk much about. And with the exception of coming in once a year for an exam for women that are able to, doesn't get a whole lot of attention. So typically with vulvar cancer, what we're going to be looking for is a new either painless or a painful itchy bump that continues to grow and bleed, or it can actually be with a light scratch or a touch that it forms kind of an ulceration. Most vulvar cancers are going to be associated with HPV, and that's another good reason to go for the vaccine because it can help prevent vulvar cancer in addition to cervical cancer. And you're going to see this often in patients that have a history of chronic vulvar itching that eventually cancer will develop.
So I know we're getting towards the end of our time, but I just wanted to highlight some of the take-home messages and what I think is most important in 4 of the gynecologic cancers that we see. For cervical cancer, for me, it's the fact we have a vaccine. We can prevent it. We can, have it be non-existent. It can become the smallpox of the future. And so I think that the fact that HPV vaccination can help prevent cervical cancer is my take-home message, and that I would recommend seeing if, yourself or daughters or sons or nieces, nephews, cousins could go out and get the vaccination.
With uterine cancer, definitely the take-home message is it can be caught early by evaluating any sort of abnormal bleeding. So if you're a reproductive age woman or you have a patient that's a reproductive age woman that says their periods have changed, it should warrant evaluation. And any postmenopausal woman, whether it be your grandmother, your aunt, your friend, your neighbor, if they say they have any bleeding, they should definitely go into a doctor and be evaluated.
And for ovarian cancer, this is the one that's most likely to run in your family. And so knowing your family history, knowing who, and these are people who are related to you. So it's mostly grandparents, parents, aunts, uncle, and children. If you have multiple people who've had ovarian cancer, multiple people with breast cancer, pancreatic cancer, male breast cancer, then it is something to be thinking about in terms of thinking about your own symptoms and being particularly wary and having a low threshold to be evaluated by a physician, or if you have access to genetics testing to be tested yourself for a BRCA mutation.
And then lastly, with vulvar cancer, pay attention to any new itching or any new bumps that you see on your self-exam or that any family member, friend, neighbor may ask you about. Again, that can be something that's abnormal and should definitely be evaluated by a physician.
I'm glad you brought up the point about young boys also being vaccinated starting at such a young age, you know, and I don't know, I hope that that is being followed by the pediatricians and family practitioners and so on and so forth. So I think, again, it is often cervical cancers just in mindsets are associated just with women, but the causes are really, it's an infectious process, so infectious method. So thank you for expanding on that as well.
No, absolutely. And it's associated with so many other types of cancers too, that
Yes.
It can be useful for all.
For all of them, exactly. How?
I have a question.
Yes, go ahead.
So, can one be reinfected with HPV after being treated without sexual transmission?
The short answer is no. The long answer is that, so it is a sexually transmitted disease, so it can be transmitted by any type of sexual interaction. So it isn't necessarily, you know, intercourse. It can be oral sex. It can be, I mean, there's some discussion about like toys and things like that that could also transmit HPV. But it does require sort of some type of transmission that is related to sort of sexually transmitted activities. It is possible that we don't have a treatment in terms of getting rid of the HPV completely, and there are many HPV strains. So unfortunately, if you are infected with, if someone has been diagnosed with HPV-16, even if they clear the virus by themselves or after a treatment such as an excision or removal of the abnormal cells, then if you then are exposed to HPV-18, unfortunately, then that would be a reinfection. And I do believe that there are cases where we don't see the HPV for a while in the test, and then it can come back. And so that could look like it was, like it had, you know, gone away and come back without sexual activity, but that it had sort of been there and sort of dormant the whole time. Dr. Hall, I don't know if you have.
No, that's a great point. I think one of the things that I see very commonly in my practice is HPV can lie dormant for years, if not decades, in patients.
Yes.
So it's not necessarily that the patient gets reinfected when they've had prior treatment for cervical dysplasia or even cervical cancer, but HPV has this wonderful way of hiding in our own DNA and just sticking around for way longer than any of us want it to. And so even if it's not with a new sexual exposure, all it takes is one exposure in your lifetime, and if it's there, it can actually pop up years to decades later without true reinfection.
Okay. And then there was another question that we took over the notes was, do you have information about high adverse childhood experience, ACE, high adverse childhood experience scores increasing the onset of cancer as an adult?
So I'll be honest, I'm not familiar with any information with that in the gynecologic cancer patient population. I will be honest, I'm not an expert in all adult cancers, really only gynecologic cancers, but specifically with the cancers that we treat, we do not have any linkage between the ACE score and onset of gynecologic cancers as an adult.
Okay, thank you.
I have another comment. For ovarian cancers, as you know, as a gastroenterologist, the way they presented to us were ascites. Yes, all those vague symptoms you presented often were overlooked because it could happen you know, But ascites, so they would be worked up for alcohol, disease, liver cirrhosis, et cetera, et cetera. But if we didn't seek this, we would miss it.
Absolutely.
So, yeah, so that is such an important thing. Again, you talked about the peritoneal presentation and so on and so forth. So ascites, which is fluid in the abdomen, so you're not just getting fat, but you're gaining weight, and that's fluid weight as a result of ascites. And it is actually a sign of metastasis. Correct?
Correct.
Yes.
The question is, if HPV can be dormant, how does one know about the source of the infection or how they were infected, especially if it was through asexual contact?
That is a wonderful question. And the unfortunate answer is we often are not able to trace the source of infection. And that's part of why HPV is so prevalent, at least here in the US population, where it's estimated that over 80% of the US population is HPV positive at some point in their life.
Oh my goodness.
Yes, it's really one of those that we don't have a good way to look and trace back like you do with several other sexually transmitted infections and go back and contact partners and get them treated because it does have this ability to lie dormant. Dr. Hoppenot, I'm sure you probably see kind of the same thing if you're not really able to trace the source of infection in most of your patients.
Absolutely. And unfortunately, we don't have a treatment. So unlike gonorrhea or chlamydia, where we can give antibiotics, we can't get rid of the HPV. And so it's also hard to tell women and their partners. I mean, condoms can help decrease the risk of transmission, but even condoms aren't 100%. So if they're looking for something to do to help decrease transmission, I do recommend condoms or having their partner vaccinated, which I've actually done for some of my patients. If they're, if they have one partner and they're able to have that conversation with them. But I do think that it is very difficult to sort of trace where it comes from.
So really, the partners also need to be vaccinated. You mentioned it that this was approved only about 10 years ago. Is that correct?
At least 10 years ago.
At least. So the majority of us then have not been vaccinated.
And unfortunately, the approval is only until age 45.
Okay.
Because that's when it has the highest impact. And part of that is in terms of that's the time where many people have more partners, I think. But it's also in terms of the length of time that it takes to then turn into cancer, that aiming for the younger women is really the highest, men and women, is really the highest yield.
Is the HPV vaccination for even previously infected people?
Yes.
Yes. Because it covers more than just one strain of HPV. In the past, there was some debate on this, but there is good data supporting that because there's multi-strains that the vaccination will protect against. Even if you've been infected with one particular strain, you'll get benefit from the other vaccination strains that are covered.
So once one is infected, they'll always be HPV positive, even if it goes away.
Not necessarily. So the body can clear the HPV. I think that one thing that we were talking about it being dormant is that we can't say for sure that it will not come back. But there are definitely many women where the HPV goes away and when we test, it's negative, and it stays negative. And that's actually very reassuring.
Okay, thank you. So once they're infected, they'll always have HPV, even if it goes away. So the best way is to get the vaccine, even.
I'm assuming that's
after vaccination.
Even after infection.
Even after infection. Okay.
And yes, I would recommend that just to prevent infection with another strain of HPV, just as Dr. Hall was saying, and some would suggest that potentially can help boost your own immune system against the HPV strain that is there, although I'm not sure that's been proven.
What are the series of vaccinations we give? What are the frequencies and the doses?
So for HPV, we give it once and then 2 months later and then 6 months later. And usually for, after age 15, it would be the 3 doses.
All right. And then Nadine says to everyone, thank you. It's very informative.
Well, thank you for all your questions.
Absolutely. Thank you for the opportunity to speak tonight.
Okay. Dr. Satya, would you like to have any closing comments before we say goodbye?
Well, again, I want to thank you both very, very, very much, Dr. Hall and Dr. Hoppenot, for joining us and educating us. This is, again, very, very eye-opening, and I love that map also that you showed as to the prevalence and incidence rates. So literally, those are the places this lecture will be going to. So and then when you showed the Minister of Health from Rwanda, my heart just sinks, because right now I'm working with Uganda and Sierra Leone and these ministers of health in Zambia, all of them. So this will be going there. So I just want you to know how impactful it will be. And I want to thank you all. And I want to invite all the audience as well as our speakers to join us on Women's Health. We're celebrating October as the Breast Cancer Awareness Month, as you all know. So we decided to do a cancer awareness run. And given our COVID, we said, well, despite all odds and despite COVID, let's continue to have it. And we chose to do it virtually. And so now, because it's virtual, I said, let's do it internationally. So we're hoping to have all these countries, several countries, participate in this event. And at the same time, we will be giving a lesson on women's health and awareness, also virtually, which will be transmitted again globally. And we are excited to say, just to add a cherry on the top, so to speak, that the Guinness World Record was very, very interested in what we're doing and wanted to get involved. And officially, we are partnering with them as well. And we are going to attempt 2 Guinness World Record events in one day. So remember 10/10/2020. And so we would like for each one of you to participate in that. So of course, a feather in your hat to say you were actually successful at it too. So welcome everyone. Thank you. Dr. Climie?
Yes, ma'am. Dr. Satya, just very quickly, you can go to our website, which is cpoi.org, is it?
Yes, sir.
And there's information about this run. We will be starting archiving videos such as this there, so that you, if there was something that you missed, you are invited to come back to our website and you'll be able to view this again. And as we just said, this is going to be actually disseminated worldwide. The Collective Power of One International has been very busy in working with nations, all around the world, and just giving them the moral support. We just had a note that popped up here. I listened to this with my daughter. Thanks for the great information. And so kudos to you guys. Yes. And then also, we're trying to do this run in 100 different countries. And since it's all, virtual, you can go ahead and run with, there's a program that they're using. And when you're ready to start your run, whether it is a 5K, a 10K, or the 22.5K, you'll log in and sign in. Okay, I'm starting my run, and when you finish the run, you'll go ahead and sign back in again, and that will recognize you as being a participant in the run. And so, as Dr. Satya said, we are officially recognized by Guinness World Records as attempting to make these 2 record attempts. One will be the largest female health, I think it's
health awareness.
Right, health awareness for cancer. It'll be the largest lesson in the world. And then the virtual run will be the largest virtual run in the world. And so we're excited about that. And, we don't do these things so that we can, say, well, we want a Guinness World Record, but what it does show is that more people are being impacted about these things that, you know, even though I've been in healthcare for, you know, all of my adult life, you know, some of the statistics that you doctors were so, you know, gracious in sharing with us. I mean, I was just blown away. And so, you know, this is a great educational opportunity also. So we thank everybody that has joined us, and we hope to be able to do many more. Dr. Satya, back to you.
Thank you all, and stay safe and stay healthy. And good night.